Who uses volatile anesthetics?
Like,
Oh, thank you. And who uses volatile anesthetics in the ICU? Oh, okay, but it seems this is a new topic and an unknown field. So we use volatile anesthetics more than 180 years, and now we have three after a great evolution of this agent. The main characteristics are rapid onset and offset of action of these agents. They have favorable or unfavorable side effects profile, and the reduced risk of toxicity versus intravenous agents is well known. Since we have calibrated vaporizers and we have the opportunity to monitor their effects, with a gas monitoring system or some other EEG-based monitoring techniques. So these are the basic principles and conditions of safe anesthesia, and it's an important thing that 75% of general anesthesia is under inhalational anesthesiology technique. These are carbohydrates. As we know, they are saturated with some halogens, for example, chloride, fluoride, and trifluorocarbon groups. And these three agents have main characteristics, just like the MAC that is responsible for the efficiency, the blood gas participant coefficient that is responsible for the rate of onset and offset of action. However, we know that the fresh gas flow during anesthesia has some important impact of this onset and offset of action. Also, the lipid solubility is responsible for accumulation. Metabolism is responsible for some side effects. We have boiling point, we know, and the carbon footprint is one thing that we have to mention when we talk about volatile anesthetics, because these are greenhouse effect gases and they can damage the environment. But we can reduce this risk by using active sectioning or some kind of scavenger systems. The main mechanism of action of these agents are to activate the inhibitory and deactivate or inhibit the excitatory pathways in the brain. So they have some neuroprotective effects, some anticonvulsant, some potent anticonvulsant effects also. However, due to cerebral and peripheral vasodilatation, in a dose-depending manner, they can reduce extremely the cerebral blood flow, or they can elevate the intracranial pressure. So we have to think about these side effects if we use it with conditions affecting the brain. However, they are very potent bronchodilators also, as we've seen in this nice paper from my group more than 10 years ago. And this is a quite new systematic review, about sevoflurane use in bronchospastic conditions in ICUs. And they found that sevoflurane has the potential to treat patients through an improvement in respiratory acidosis and airway resistance. So they are potent vasodilators, and these are the two common indications in the ICU, the refractory epilepsy and refractory bronchospasm. However, there are some obstacles and limitations we have to deal with if we use volatile agents in the ICU. Fortunately, we have at least two kinds of devices, the MyRisk controller and the Sedaconda. That is a micro vaporizer responsible to give the patient the agent and to scavenge it or to absorb it during exhalation. We can use a very simple syringe pump to give the patient the agent via the Sedaconda, and we can change the syringe pump rate based on the minute ventilation of the patient. There are many advantages of volatile anesthetics: the rapid onset of action, we can easily control the depth of anesthesia, we can monitor it with physical signs or with some monitors. We can preserve spontaneous breathing during mechanical ventilation. The rapid offset and recovery is well known. The minimal metabolism is a good thing. There is no withdrawal syndrome when we stop introducing this agent. We can spare opioid use. However, the mechanism is unclear why they have this opioid-sparing effect, and they have some organ protective and anti-inflammatory or immunomodulatory effects also. We have to talk about some disadvantages also. If we use volatile anesthetics, we can't use active humidification. If there are many respiratory secretions, we cannot use them, or it limits its usage. The fluoride toxicity, the ICP elevation are well-known risk, and malignant hyperthermia is also really rare, but we have to think about it every moment. And there are some equipment requirements that are not so cheap, however, they are expensive. How can we use volatile anesthetics in ARDS? Because this is maybe a new indication for volatile sedation. If we think about ARDS, we have to treat first the underlying pathology. We have to take care about sedation to prevent pain, agitation, delirium, and sleeping disorders. We should protect the lungs, and we try to reach some immunomodulation also. So let's look at the topic from the sedation perspective. We know that light sedation results in better survival, even in 90-day survival, and 1-year survival was better in this study when they used light sedation versus deep sedation. What can we achieve also with early sedation, early light sedation in patients? The mortality, the days on mechanical ventilation, and the length of ICU stay was reduced significantly. Delirium, the decrease in delirium was not significant, but there was a quite tendency that light sedation can reduce delirium, the presence of delirium and the duration of delirium also. And if we think about this picture, the duration of delirium has really important impact on post-ICU cognitive function. So the more longer the delirium, the more longer will be the cognitive impairment. So we can conclude that ARDS, or treating a patient with ARDS, is not equal with deep sedation, except from some scenarios. So light or even appropriate sedation is recommended, I think so. There are two large ongoing trials, the INSPIRE ICU 1 and 2, using isoflurane to sedate patients. And the primary outcome is the percentage of time under target sedation. And the secondary outcomes are opioid exposure, the preservation of spontaneous breathing, the time to wake up and end of treatment, and the cognitive recovery after treatment. However, we have no results yet. So, what does the jury say? Volatile anesthetics are good for intensive care sedation. And what about the mechanical ventilation? We all know pulmonary protective ventilation. I won't go deep into this topic now, but how can volatile anesthetics help us? This was a trial comparing the PF ratio in patients sedated with propofol versus volatile anesthetics, and they found, midazolam, and they found a significant improvement in PF ratio when patients were sedated with volatile anesthetics. So this is a positive result. However, it's only one study, So we don't exactly know now where we are in this case. What about eliminating carbon dioxide? We all know if we put something into the breathing circuit, it will present some dead space. And this can cause elevation in arterial carbon dioxide tension. So this was an experimental study using lung test models, and they compared the three types of microvaporizers, the Mirus, the 100 milliliter and the 50 milliliter anaconda or sedaconda devices, and all of them elevated the end-tidal carbon dioxide significantly. They made the experiment further. They compared the effects with PEEP of 5 centimeters of water and with 15 centimeters of water or so, and they found that all of them elevated the mechanical power of ventilation significantly. It's a sign that we have to take care and we have to be alert when we use volatile anesthetics. However, these are experimental studies, and these results cannot be considered general, but they are noteworthy. So what does the jury say? We don't know where we are. What are the potential benefits to prevent ventilator-induced lung injury and ventilator-associated pneumonia? We all know our goals, and these are the cross-section of these two circles. We would like to reduce atelectasis, volutrauma, and some other injuries. How can volatile anesthetics help us? They can, or at least isoflurane, can activate the retrotrapezoid nucleus and the brainstem responsible for spontaneous breathing activity, while propofol inhibits this nucleus. So it was a really nice experiment, really nice study. They found that preserving spontaneous breathing using isoflurane was superior to propofol in this case. What about survival? Because our main goal, one of our main goals, is to, if we reduce the risks, we expect some improvement in survival. And in this retrospective analysis, they found that isoflurane was better in survival versus propofol or midazolam sedation. However, it's a quite new result from this year, the CESAR randomized trial. They found that the mortality was worse when they used sevoflurane sedation versus propofol sedation. But the study was conducted during the COVID pandemic. There wasn't any effective training, and this impacted the therapy. The shortages of ICU staff is well known for all of us. Most participating ICUs weren't familiar with the inhaled sedation techniques. They didn't use anesthesia monitoring, and the main extent of patients were sedated too deep, and they used neuromuscular blocking agents also, and its patients required very high doses of norepinephrine, and the mortality was mainly due to refractory circulatory shock. So what about protective ventilation? It seems good, but we don't know. And what do we know about immunomodulation? We know that during ARDS, pro-inflammatory mediators are in the alveolar fluid. There is a progressive injury due to chemotaxis, neutrophil activation, the natrium kalium ATPase deactivation. But isoflurane and sevoflurane can deactivate the RAGEs, and they can activate some mechanisms that they can defend the alveoli and the epithelial cells. They can reactivate natrium kalium ATPase. So maybe it's a good effect of volatile anesthetics. And this was a randomized controlled pilot study where they found that the level of rages were also significantly lower in the alveolar fluid and in the plasma also. So what does the jury say? Inhibiting neutrophils, decreasing the level of rages is a good thing for us. And finally, what does the judge say? We don't know the exact role of volatile sedation in the ICU, and it's neither simple nor obvious, but it has a place, it has a role, I'm sure, in intensive care. It's a new tool we have to use by using our brain, but we need further studies to determine its exact role. Thank you for your attention.